Well, good afternoon, everyone. Thank you all for being here. It's pretty exciting to be at our sixth, that's kind of hard to believe, sixth annual SU Research Day. This is where we come together and highlight some of our outstanding faculty and their scholarly activities. So it's meant to be celebratory in nature and also meant to be academic in nature. And so we appreciate all of you being here, students, staff, faculty, everyone. It's a great time to kind of celebrate what we do outside of the classroom as well as the activities that we do that support our faculty and staff and their scholarly activities. For those of you that don't know the voice or the face, I'm Clifton Griffin, Dean of Grad Studies and Research here at SU. Lots of folks in our office have been a part of the logistics of setting this up, so I'm very appreciative of the staff of Grad Studies and Research for all of their activities today and the last few days to get us started. I do want to say thank you to our president, Dr. Chuck White, for making it. I know he's rushed here from a Board of Regents, a thrilling Board of Regents experience, and so we appreciate you being here, Chuck. Thank you very much. Also want to say a big shout out and thanks and appreciation for our interim provost and senior vice president, Dr. Karen Olmstead, huge advocate and supporter of research at all levels from faculty to grad students to undergraduates. So thank you all for being here for sure. So to keep us on time, I'm going to hush, which is the hardest thing I ever do, and we'll get started with our first presentation from the School of Health Sciences in the College of Health and Human Services. Did I get that right? Dr. Tom Pellinger, who's going to talk with us about going with the flow, regulation and manipulation of blood flow in health and disease. Dr. Pellinger.
Can everybody hear me? I've got the lapel. Yeah. Thank you, Dr. Griffin, and everybody for coming out today. I'm going to talk about blood flow regulation. Little brief outline. First, we're going to talk a little bit about blood flow regulation and its importance, generally speaking. I'm going to talk to you about a little bit of background and a couple of specific research studies, and then some basic and clinical implications of those studies. I'm going to follow that up. We'll shift gears a little bit and talk about peripheral arterial disease, a little bit about what that disease is about. I'm going to highlight two interventional studies that one was finished and one is almost finished. And then we're going to wrap up with some overall conclusions and implications of the research, as well as some future directions. So this is a distribution of blood flow in the human body at rest. And as you can see, there's a lot of blood flow going to places like the liver, the digestive tract, the kidneys, right? But my question for you is, how will this change when you start to exercise? Where will that blood flow be redistributed? Skeletal muscles, of course. Yeah, that's logical, right? Skeletal muscles. A lot of it goes to skeletal muscles, and it's shunted away from the liver, the kidneys, the gut, that sort of thing, right? So blood flow regulation is primarily mediated by resistance vessels called arterioles. Arterioles can constrict to direct blood away from vascular beds, or they can dilate to direct blood toward vascular beds. And that's what we see right here is the arterioles. Here's a little example of blood flow regulation, very simple example. So you have a sympathetic neuron, and it releases a neurotransmitter called norepinephrine. Norepinephrine binds to alpha receptors, and when that happens, you have vasoconstriction. So that's an arteriole constricting, smooth muscles contracting. Furthermore, you can have blood-borne things that can bind to receptors that can cause further constriction. But on the other hand, you have blood-borne things, usually products of exercise, that can cause dilation when they bind to receptors. So there's a lot of things regulating blood flow all at the same time. This is a video clip from some imaging with Doppler ultrasound of a common femoral artery. And so the common femoral artery is right about there in the groin region. And you can see that's a pretty clear picture of blood flow. There's the flow, and this is actually just an ECG right here. So this is a very powerful tool when we're talking about assessing blood flow. And a little thing we know about that post-exercise period of time, which we just looked at there, is following only an hour of moderate intensity exercise, there is a really sustained elevation of blood flow to skeletal muscles, right? And we see that from this data here. I want you to focus on leg vascular conductance. That's actually blood flow divided by mean arterial pressure. Here's pre-exercise, and here it is elevated for 100 minutes post-exercise. So that's a pretty long amount of time for blood flow to be increased to skeletal muscle after exercise is done. So one of the mechanisms of this has to do with H1 and H2 receptors. H1 receptors are located on the vascular endothelium, H2 on vascular smooth muscle. And when they're bound, they cause this really large vasodilation, right? And I have the H's, which roughly represent histamine, but there are other things that can bind to them as well. We'll get to that a little bit later. So how much is this effect? It's pretty substantial. You can see here, this is change from pre-exercise baseline following exercise, and you can see a large elevation in blood flow. And we know it's mediated by these histamine receptors because if we block the histamine receptors, look what happens to femoral vascular conductance. It's blunted by about 80%. So you wipe out about 80% of that elevation in skeletal muscle blood flow if you take two drugs. One of them is Allegra, which is an H1 antagonist, and one of them is Zantac, which is for acid reflux. It's an H2 antagonist. So these are very, very common drugs. So my question when I started diving into my doctoral work is, what is the function? We know the hyper, and by the way, hyper means high, emia, blood. Hyperemia simply means high blood flow, right? So what is the function of this elevated blood flow following exercise? We didn't really know, right? Well, at first we thought it could be oxygen uptake, the muscles taking up more oxygen following exercise. But what we found is that's actually not the case. We actually don't see a relationship, any sort of temporal relationship at all between the oxygen uptake and the elevated blood flow. So it doesn't appear to subserve elevated blood flow too much, or oxygen delivery too much. So my thought went to recovery. My thought went to metabolic regulation. Right? Following exercise, there's a whole market for supplements to increase recovery after exercise. There's just a few examples of them, right? And we also know that following exercise, you have increased glucose uptake and increased what we call glycogen repletion. All glycogen is a bunch of glucose is put together. It's a storage form of energy, and it's in your skeletal muscle. And we know after exercise, you can store a lot of glycogen in that first 90 minutes or so. So this is a really brief overview here, and I'm really going to focus on this part. What happens with the glucose uptake? Well, you have glucose floating through the bloodstream because you've eaten something, right? It goes through the capillaries, and then it goes in what's called the interstitial space, which is essentially a space between the cells. You have insulin, which is released from your pancreas, that binds to an insulin receptor, and this GLUT4 receptor transporter comes right here. Glucose comes in, and then downstream, it undergoes metabolism. Well, our focus is on the perfusion, the actual blood flow getting to that skeletal muscle. What's that all about? Right? So the first research question was, if we blunt this post-exercise hyperemia via this H1 and H2 receptor blockade, do we also reduce glucose delivery to the skeletal muscle? That led to this publication right here. And I want to tell you a little bit about muscle microdialysis. Muscle microdialysis is a technique that we use to get at this, and it's a pretty invasive technique. It's actually surgical. And what it involves an insertion of muscle microdialysis probes. What you have to do is you have to take a spinal needle and run it through the muscle. And the muscle that we looked at was the vastus lateralis, the outer thigh. You pop it in one side, you pop it out the other side, and then you take a fiber and you lay the fiber in, and then you pull the spinal needle out, right? So this is a pretty invasive technique. I did this on pieces of fruit and dead people is a better name for that. Yes, thank you, cadavers. Before I did it live on real human beings that were functioning, right? Thank you for that. So then you infuse this physiological fluid into the muscle, right? That's called the perfusate. And then you collect it on the other side, that's called dialysate. And in between, you have these pores. So depending on concentration gradients, things can go into the fiber or they can come out of the fiber. You can sample the substances from the interstitial space, that space between the cells, and you can also deliver drugs to the cells, which is important. Right? And most importantly, you can look at dynamic changes, not changes in 1 second in time, but changes over hours, right, by using this technique. And in the particular study that we're looking at, we inserted 4 probes, like I said, 2 that are control probes that are just normal physiological fluid, and 2 that had those same blockade drugs I mentioned before. So that's just like the Allegra and the Zantac that you can take orally, but it's via dissolved fluid. So this is what it looks like when it's all set up. There's our subject, happy, laying down, relaxing, 4 probes in his, what's a his leg? Okay. And we hypothesized that this post-exercise skeletal muscle interstitial glucose concentrations would be higher in the control fibers, the ones that didn't have the blockade, than in the combined antagonist fibers. There's a lot going on here, and we're not going to go through a lot of detail, but just know that they came in, we laid them down, we anesthetized the area because this is a surgery. We had them either exercise for 60 minutes or just sit on the bike and rest for 60 minutes. And then immediately after exercise, I'm going to work putting these probes in. And clearly this is done in a soundproof room for obvious reasons. Not really. You're like, is he serious? And then we collect dialysate afterwards, that fluid. And then I want to make a note that we give an oral glucose load. That basically was mimicking a post-exercise meal, right? A lot of people like to eat right after they exercise. A lot of people, that's the reason they do exercise. So what did we find out? So blood flow, up here is the control day where no exercise was done. And when there was no exercise, no effect on the blockade, 0 effect. Right? However, if you look at the bottom panel, and by the way, this is a little counterintuitive, but the lower the numbers, the higher the flow. The higher the numbers, the lower the flow. I'm not going to get into all the science behind that. But this means there's greater local blood flow at the control sites. Right? So the sites that didn't get the blockade had more blood flow. Right? So that's part 1 of the findings. Part 2 is, well, how did that affect glucose delivery? That's kind of what the bottom line what we're after here. Well, once again, in the sham, no effect at all. However, if you look at following exercise, and this is where the oral glucose load was, the drink, right? So that's why it's going up. But you see at every time point, you see that the control condition, the control fiber, you had more glucose in the interstitial space ready to go into that muscle cell versus the blockade. So that does suggest that this increase in post-exercise blood flow also mediates the delivery of glucose to the muscle. So, oh, a happy subject. OK, so the main conclusion, the main take-home is local H1 and H2 receptor blockade in the skeletal muscle receptors appear to contribute to both elevated blood flow and elevated glucose delivery following exercise. Right? So our next research question has to do with insulin sensitivity. So we said, if we blunt this post-exercise hyperemia via those same drugs, what will happen to post-exercise insulin sensitivity? And I'm going to give you, and that led to this project right here. And a lot of people don't understand glucose uptake or insulin sensitivity. I mentioned it a little bit. I'm going to go through really quick. I'm going to use an analogy that I use with my students. It seems to help them remember. This is Gary. Gary wants to go to the nightclub. He wants to get into that nightclub very badly. In order to get to the nightclub, he has to get past the doorman. The doorman has to let him in, right? If he's OK, oh, sorry, we'll get to that in a second. He needs Ingrid to come over there and talk to the doorman. Right? The doorman wants a certain ratio of women to men in the club. Ingrid needs to come along, or Gary's not getting in the club. Right? If Ingrid comes up and talks to the doorman talks to George. George is inside the club. He comes to the doors, opens it up, and Gary is home free. Gary gets to go into the club and have a good time. Right? However, there can be things that interfere with this. Right? We'll get to that in a second. Gary represents glucose. The club is the muscle cell where the glucose wants to go. This guy represents an insulin receptor. And Ingrid, you probably figured it out, represents insulin, which is released in the pancreas. So if Ingrid's on board and she binds to, that's maybe a poor choice of words, but if she activates, or there's a lot of words, science words, the doorman, then he's home free. But there's one problem. There's something called insulin resistance. And that is Ingrid's girlfriend who had a bad day. She failed her physiology exam, right? And so she wants to go eat ice cream or something with Ingrid. And so she pulls Ingrid away from the bar so Ingrid can't activate the doorman. And therefore, who's left sitting out in the cold? Gary. Yeah, Gary's just sitting out there, right? Can't get in. Insulin resistance, right? All right. So our hypothesis in this particular study is we hypothesize that insulin sensitivity following this bout of exercise would be reduced in the H1, H2 receptor blockade compared to the control. And there's a lot of stuff going on here, and some of it you don't necessarily have to get. The students get really excited when they see the hot box. It's not what they think it is. It's literally a box that heats up your hand, right? And when you heat up your hand, it actually causes blood in the arteries to shunt directly to the veins. Why do we do this? Why would you want to do this? Well, the reason is putting a needle into an artery is very invasive. Running an IV is not so bad, right? So we take advantage of this physiological phenomenon to draw blood off the vein, right? And not have to go into the artery, right? So they came in, they get instrumented. Once again, they exercise or they hang out, right? There's a control day, there's a blockade day. And then post-exercise, you get a little oral glucose drink again. There it is right there. And then we take all these measurements, right? So post-exercise hemodynamics. This is probably who knows how many times this has been shown already. So I'm just going to tell you, at this point, the fact that you had this post-exercise hyperemia and it's blunted by the H1, H2 blockade is very well established. As Champ Kind would say, it's a scientific fact at this point, right? It's been shown enough. And that's what we see here. No Anchorman fans? OK. And this is showing us a little bit about hormones. So if blood glucose is elevated, there's more blood in the glucose, then what's going to happen to the pancreas? It's going to say, we need more insulin. We need more ingrids, if you will. So the pancreas is going to pump out more insulin, right? And you also have another hormone called C-peptide, which we won't get into, right? And what that tells us is this hyperemia affects normal blood glucose regulation. And if you block it, you adversely affect normal glucose regulation, right? And for the big finale here is insulin sensitivity. That's their big outcome variable. Well, once again, you've got control, blockade. Here's the exercise. The post-rest, post-sham. Nothing happens to insulin sensitivity post-sham. The drugs don't affect insulin sensitivity all by themselves. But following exercise, you see a substantial difference between the control day and the blockade day, right? Which really suggests that post-exercise insulin sensitivity is adversely affected by these common drugs, Allegra and Zantac. So, post-exercise H1, H2 receptor-mediated skeletal muscle hyperemia mediates normal insulin sensitivity, and these are healthy humans at this point. So there's a lot going on here as well, but this is an arteriole, right? This is a resistance vessel, and then you have a capillary. If you block these receptors, as we've shown, if you block them, you reduce blood flow to those capillary beds. Less blood flow also means less insulin's being delivered. Remember, insulin's ingrid. Insulin helps the glucose get to the cell, and less glucose. So that means there's less opportunity to get glucose into the muscle cell. We don't know what happens to this GLUT4 transporter. That hasn't been studied, and that's why there's a big question mark there. Right? All right, so what are some clinical implications, or basic and clinical, right? Well, first of all, our concerns start to shift to people with metabolic disorders, and most notably diabetes. People with diabetes have insulin resistance. They also depend on regular exercise to regulate their blood glucose. Right? It's very helpful for them. Right? So there's implications there. Normal insulin sensitivity appears to, and that, we're talking normal, healthy people, appears to be manipulated, unfortunately, by these drugs. And last but not least, these antihistamines may limit the rate of glycogen, remember that's that stored energy, resynthesis, delaying muscle recovery. For elite athletes like this guy, Eliud Kipchoge, anybody know what he just did recently? Broke the world record, broke the marathon world record, 2:01:30 something, amazing, incredible. I have a colleague who's worked with him quite a bit. He says he's a great guy. All right, and what about relevance? Well, there's a lot of areas in this country that have a lot of pollens and allergens, right? Makes you not feel so good. So you take Allegra. So there's a lot of people in this country that take Allegra, a lot, right? And this is America. We also like to eat, and sometimes we overconsume, right? Who can tell me who this guy is? Who? Oh, somebody had it. Kobayashi. Proud of you. That's awesome. Okay. Yeah, he was a championship hot dog eater for many years. I think there's another guy who's beating him now, but I love that picture. And if you overconsume, you have to take Zantac because of acid reflux and whatnot, right? All right. To shift gears for the last few minutes here, we're going to talk about peripheral arterial disease. This is actually a fairly low estimation. Roughly 12 million people, most of the data shows, have peripheral arterial disease in this country. And the main problem is it hurts when they walk. They have plaque that's built up on their arteries and their legs. It reduces blood flow, and it's painful to walk, so they don't walk, right? And that is a problem. This shows an example of the plaque, and here's a bunch of blood vessels that could be blocked, right? So the suggestion is exercise, but it's painful to exercise, so they're not compliant with the exercise program, they're not adherent, and they don't get the benefits. Well, that's a problem. So the question becomes, well, how can we improve exercise tolerance in these patients that have PAD? Well, there's a couple different things that we've learned fairly recently. There's recent evidence that suggests when you heat a limb, you not only increase blood flow to the skin, which we already knew for quite a while, but you increase blood flow to the muscle, right? So that's one thing to consider. The other thing is the use of transcutaneous electrical nerve stimulation. That's a technique that physical therapists use a lot of times to reduce pain. That actually can induce transient increases in leg blood flow and reduce onset of pain when they walk. So there's an opportunity here. The opportunity is to say, can we use these interventions to improve quality of life in these patients? So the last research question, can non-invasive techniques, non-invasive, not surgical, right, be used to increase leg blood flow, therefore increase exercise capacity in patients with PAD? Well, this was just published this year. I'm going to talk about this briefly. We predicted a single bout of lower leg heating for 15 minutes or 45 minutes would increase blood flow and improve 6-minute walk distance. So not only are you increasing the blood flow, there's a functional benefit to it. Well, that's what we thought anyway. So here's what we did. This is not a patient with PAD. This is a former student we're doing some pilot work. So we get him in. We do a bunch of measurements. The main one that pertinent to you guys is the blood flow measurements, Doppler ultrasound. So they lay down, they get measured. Then they sit up and they put their lower legs in this bath, which is very comfortable. The subjects really enjoy that. And then immediately afterwards, they lay down again, and we take all the same measurements again. And then last but not least, we have them do a 6-minute walk, which is a very common clinical thing. So it is a 6-minute walk. We say, well, how far did they walk as a result of this, right? Well, what do we find? We found good stuff, right? Lower leg heating appeared to increase the popliteal artery blood flow. So here's the control visit. Here's 15-minute heating. These are 45-minute heating. And you can see, compared to pre-heating baseline, there's this elevation of blood flow. And it's very duration dependent. 45 minutes of heating gives you way more blood flow than 15 minutes of heating, right? And then the bottom panel is looking at 6-minute walk. What you see is both durations of heating improve 6-minute walk distance fairly similarly. There's just a small greater increase for 45 minutes. So 6-minute walk appears to increase similarly during both durations. So the bottom line with this is, you do the lower leg heating, as short as 15 minutes, this isn't very long, right, to have your legs in a little hot tub, right, increases post-heating leg perfusion, blood flow, and walking capacity in these patients, which is key. Right? And last but not least, we looked at the TENS. This is essentially the same protocol, but instead of using lower leg heating, we used the TENS unit. And we had a certain setting that caused little muscle twitches, little contractions, right? Subjects not exerting any energy at all. The machine's doing it for them. So we said, well, same idea. If we do this TENS, we're going to increase blood flow, and we're going to increase 6-minute walk distance. So this should look similar, right? Same idea here. They lay down, do some baseline measurements. We do the TENS for 15 or 45 minutes, or we do a control day, post-TENS measurements, and then we have them walk. And sort of similar to the heating, we do see that this popliteal vascular conductance is higher in the post-TENS condition versus the controlled condition. So it does appear that blood flow goes up. It does go up. It does go up after the TENS. And then what about walking? Is there a functional response? And there is. What you see is compared to control, in the 15-minute, you have a greater distance of walking. In the 45-minute, you have even a slightly greater improvement in walking. But once again, not dramatically different between 15 and 45 minutes. Pretty similar. So what does that tell us? Well, it suggests as little as 15 minutes of TENS is going to increase leg blood flow and improve walking capacity in these patients. So overall conclusions. Let's look at the first part first. H1 and H2 receptors appear to mediate normal post-exercise glucose delivery and insulin sensitivity. Now, so far, just in healthy people, so far. Right? These common drugs, and they are very, very common. Many people in here probably take Allegra and or Zantac, right? May interfere with glucose regulation, and this is ranging from diabetics, potentially, insulin sensitivity, right? Or highly trained athletes, the person that runs 130 miles a week, who's training twice a day. They depend on glycogen repletion to recover for their next bout of exercise. And with the PAD, lower leg heating and TENS both appear to increase this post-innovation blood flow and walking capacity, improving actual quality of life, functional capacity. The important thing to note here is these are non-invasive interventions. They're cheap and they're easy, right? The alternative might be to have surgery on your blood vessels. Not so fun, not cheap, not easy, and it's very invasive, right? So that's what's gathered a lot of attention, the fact that we can do this fairly simply. So where should we go in the future? Well, I mentioned glycogen repletion. doing studies that say, how do these drugs affect the repletion of glycogen stores following a bout of exercise, that would be helpful, especially with high-level athletes that train a lot. Right? And then, once again, diabetics, which I've already talked about a little bit, and then training studies that say, well, is the pattern we see acutely the same that we would see over months or even years? And finally, we need to confirm the mechanisms, the specific mechanisms of the PAD. We know it increases blood flow, but what exactly is it that causes the increase in blood flow? And then, similarly to this, long-term. What happens if somebody with PAD does leg heating for 6 months, 8 months, a year? I'm actually working with a colleague right now in Texas that is doing that right now, basically doing the long version of the study that we did, right? A chronic study. Right? So with that, I want to always thank the subjects because they're the ones that we poke holes in, right? And a bunch of collaborators, some from University of Oregon, a lot of them from here, and of course funding. Can't do any of this without American Heart Funds initially, so, Evan Memorial, and of course the Salisbury University Faculty Mini Grant, which was pivotal in paying our subjects for the research here. And then of course these future scientists that just happen to be the guys that I come home to every night. So with that, I'll be glad to take any questions you have right now.
So I'm curious if there's any evidence that there's like a cumulative effect of these drugs, or would it be beneficial to, for instance, wait until after I exercise to take my Allegra?
Oh, okay. That's a loaded question. And the reason I say that is because drugs have different half-lives. So how long does 50% of them degrade? You could argue that you could maybe manipulate the timing of the drugs a little bit, but if it's a drug you only take once a day, probably not going to have an effect, because the therapeutic effect of the drug lasts for 24 hours. So it depends on the drugs. Their half-lives are medium. So yeah, that would be actually an interesting question. That's something we could look into, actually, and see if when you take the drug. Because when they come into the lab, as soon as they got to the lab, they took the drugs. As soon as they got there. And so they were already affecting them adversely, of course, within an hour. Yes? Oh, I'm sorry. I'm looking, okay, yeah, yes.
I have a couple of questions. The first one is, what about so for the heating, what about the muscles heating up when walking? I mean, does that add into it, the benefits to the increased perfusion?
That's an excellent question. So people with PAD, a warm-up will help them, but sometimes even the warm-up intensity is painful, right? So we're kind of taking that out of their hand, not taking it out of their hands, but we're helping that process. A number of other things happen. Enzyme activity increases, right? So metabolic reactions can go faster when the enzyme's been warmed up. So that's what I meant by specific mechanisms. We know the blood flow increases, meaning you're perfusing the muscle with more oxygen, nutrients, so forth, right? But it could be enzymes that are being manipulated or some other metabolic process that's being manipulated as well.
Okay. My other question is, you said specifically Allegra, right? What about something like Benadryl, where the pharmacodynamics are a little bit different? It's more of a short-lived.
Okay, yes. So kind of similar to Diane's question. If it is, now we just did only Allegra for this. So I can't say beyond a shadow of a doubt that, oh, you'd have the exact same effect if you used either another H1 antagonist or another class of drug for allergies, right? So we can only speak definitively, right, with Allegra. But it would depend probably, if you look at the half-life of the drug and the pharmacodynamics and pharmacokinetics of the drug, that would probably impact the responses.
Thank you.
You're welcome.
Great talk.
Thank you.
I'm curious if you looked at the interval of time in between the application of the therapy to the exercise. So it seemed to be almost instantaneous. What if there was like a time period in between the heating versus the walking?
Oh, we actually do that. So if I can maybe go back to the, and that was in my mind. You say, well, we're not going to do it instantaneously. We know there's going to be a huge increase in blood flow instantaneously. So you actually wait for, I don't know how we can, which side here. You actually wait for 10 minutes after the heating is done before we start doing the measurements. And then they actually start walking at 35 minutes. So for somebody to say, oh my God, I would have to jump out of my hot tub and immediately walk the dog, that's not the case. It's more practical than that. To be honest with you, if we had done it immediately afterwards, blood flow would have, because I was measuring with Doppler ultrasound, it would have been through the roof, and it probably would have helped walking capacity better.
So that's my question, is if you looked at the optimal time, so for example, if I know that I'm going to hit the gym at 3 o'clock, like when should I apply this heating to my legs?
Oh, I would say as close to your gym time as possible. Yeah, because it is going to start to, the increase in blood flow is going to degrade over time. Yeah, but yeah, as close to as possible. But, I mean, 35 minutes post, and they're still improving their walking.
So a follow-up question to that is, my mother has peripheral artery disease, arterial disease, 4 different doctors. Today is the first time in 10 years that I've ever heard about this potential intervention, using a TENS unit or heating prior to activity. And so the question is, how much does this kind of basic research have to be replicated before it hits the clinic?
Oh, go out.
In other words, before today, I would have known to suggest to mom, you might be able to walk down to your mailbox easier, very simple, but a practical thing, if you use your heating pad for 30 minutes before you do it.
Sure.
So how do we get there?
In general, dissemination of scientific research to physicians takes time. It does, right? There has been, the more impact an individual study makes, the more people are saying, oh, well, we need to follow up on that. I'm going to be perfectly honest with you. We went after publishing the heating project before I wanted to. We were told by, I think I mentioned this to you, Circulation, a really high-level journal, submitted there first, which we just went for it. Like top 0.0001% of all journals, right? And they basically wrote back and said, this is a well-designed study. The results are clinically very interesting. You need more subjects. If you doubled your N, you'd be good to go. So we said, well, we're going to go to another journal and say, hey, this is a fairly preliminary study, right? The reason we did that is because we know other people were hot on our tails. We're Salisbury University. We don't have million-dollar labs all over the place and stuff like that. There are other investigators that can do all sorts of crazy invasive things a little bit beyond that, what we can do right here, right now. So I said, we got to get this out there. We got to be one to plant the flag in the ground, so to speak. And then other people can say, okay, they've shown it, they've done it. Now we can come in with all our extra fancy equipment and we can do more advanced studies. Yeah. So it's going to take, so there are a lot of people looking at this right now. So that's good news for people with PAD. There are a lot of people investigating it. And so the more this is replicated and then we look at the long-term studies, the more it's going to get the attention of cardiologists, vascular surgeons, that sort of thing. Yeah.
Fantastic. Thank you so much.
Okay, thank you.
Thank you very much to all of our faculty presenters. We certainly appreciate your energy. This brings us to the end of our faculty presentation part of the SU Research Day. We encourage you to stick around, have some refreshments, and visit with the folks that are in the back. Once again, thank you to all of our faculty. Let's give them another round of applause. Fascinating array of scholarship that we heard about this afternoon, and it always is really a great opportunity to hear from our faculty. Thank you so much.